go on or interest that needs to come off, you need to shout and tell the governance team around that. We did clarify, didn't we, Stuart, that you were getting very frustrated about one that was still showing, despite the fact that every meeting you said this interest is no longer interest.
I just nearly got it right, but not quite, so I will
go back to them. Yeah, but I've been told to remind people that even if you want to remove an interest, it stays on for 6 months. So, hence the frustration. And also, we've just gone through our annual kind of refresh of declarations of interest. Some people around this table will have had an email from me yesterday reminding them that they haven't yet submitted it. I'm not looking at anybody in particular, Bushra Ali and Simon Stockwell. So,
always the DPs that are naughty.
Yes, exactly. I thought there was an irony there. Our GP colleagues not wanting to declare. And in terms of the meeting today, the main item where there is a declaration of interest for everybody who is an ICB employee or is paid by the ICB, so that includes the chairman and exec directors, is in the update from the transition committee. So we will record that now and record that also, Michelle, at the start of the meeting. And then also, just for information and transparency, there is the gifts and hospitality and sponsorship register. So as we go through the business of our public board this morning, there are some standing kind of items that we will kind of look at. We do have a number of presentations and people kind of coming into the room at various points. We will do our best to do that, but I kind of think we just need to kind of take a view as to how those things work based on our limited technology today. So if we're good to go, we can go to the minutes of the previous meeting, which were on the 10th of September. So if we go through for corrections and accuracy, first of all, we'll pick up the matters arising with the action list. So there's 15 pages. So pages 1, 2 and 3, 4 and 5, 6 and 7, 8 and 9, 10 and 11, 12 and 13, 14 and 15. Are people happy with those as being a true and accurate record of the meeting? Huge thank you, Michelle, for the minutes there. And if we go on to the matters arising and the action list, which is on the back, so that's page 16 there, just going to go through these. We're going to pick up the green plan today as part of the sustainability update. Few items under the board assurance framework. There was one, if you remember, which was around the role of quality in the new structure, and I'm going to suggest that we have some thought. I think we do Amanda to talk about an update on quality at the next meeting, but then we can start to think about for February, starting to talk about what the quality function looks like in a new look ICB. So we've got the presentation down for February, but we'll have a conversation about the other cost stuff as well, if that's okay. The medium-term financial risks were updated, that's been done, we took an action, didn't we, last time around, just after the publication of the league tables, and I think the board was concerned around the impact on staff in terms of some of the messaging that's coming out of the presentation of the league tables. And remind me, Anya, I think we were part of a system kind of reassurance to staff, an appreciative piece of communication, wasn't it, around the work that staff were doing around those things. So the subsequent one is the same as the previous one. We're having a deep dive in diagnostics, Sean, in December. That's our Christmas present to you. The feedback from the Stop Smoking campaign will come when that's available. It's not quite available yet, is it, Anya? We'll bring that back. And just something for us to sign off. If you remember last time, and this, in your absence, Nigel, we looked at the Freedom to Speak Up report, and I think the feedback from the board was it was a great report, but actually context setting it within the new world and the proposed changes around Freedom to Speak Up was probably the bit that was missing, and I think Michelle was quite helpful in helping steer us as to what we need to say. There's a copy of the amended Freedom to Speak Up report here with those amendments included. So rather than just disappearing into a darkened room, I wanted the board to have sight of that change that were made and to ask the board's approval in signing that one on. Michelle?
Yeah, it's a lot better, thank you. Yeah, I think it's, obviously it's a work in progress, but I think it picks up the points that we made last time.
Yeah, brilliant. And I think everything at the moment is a moving feast, isn't it? So we don't quite know some of this stuff, but actually it's a good report. Okay. Thank you. And can you give the appreciation back to the team for moving on that one so quickly and nicely? That'd be really. And there's 2 in progress. One of which is for nursing, which was managing reporting unacceptable behaviour in primary care. And then the other bit was about triangulation, Jane, in terms of workforce concerns as well. So those 2 things will come back to the board, hopefully for the next public meeting. Was there anything we've missed there? Okay. So, notification of any business. There is no any business that anybody's told me about, so there isn't any. So we move on to questions from members of the public. So as you know, we frequently get questions to the board from the public. What you have is we had quite a few questions. So rather than reading all these out, and please know I'm not going to read all of these out. These are the questions that have kind of been posed to us. These are the responses. The responses have been sent to the people asking the questions. They're also going to be published on the website. So questions here around MRI scans, as you can see. And then there is a second question, which is around low-level mental health services in North East Lincolnshire. And I think there is a response in here which has been sent, which I think is a response as a point in time, but subsequently I think we've made some significant progress in terms of looking at how that working with the primary care networks in North East Lincolnshire to look at sustainability of those services and supporting that. So there is an amendment to that question, a kind of an updated kind of response, which we will share with the board, but also we will send back to the person asking the question, and that will also be published on the website. It's a timing issue with this one. So they were the questions just for information, and just if anybody does want to ask questions of the board, please submit them via the website, and the board can manage that process. Okay. So we're going to move on to board assurance framework. This is you, Jane.
Thank you, Chair. There's no new risks being added to the board assurance framework, and the paper that you've got in front of you, the most important part of it is section 3, which is titled Backlist Areas for Attention. There's quite a number of items in there, but I would just draw your attention to the discussion we had last time about patient safety, which we discussed further at the executive committee, and that the patient safety and quality is going to receive greater attention. Shane, you've already mentioned what we're planning in terms of the board review. The quality committee are going to look at this further at their December meeting, so any updates resulting from that review will be submitted to the board after that. So I wanted everyone to be aware of that. And then the other one was risk A2, which is the 25-26 delivery of the operational plan, and a recommendation to reduce the risk score from 20 to 16, reducing the likelihood from 5 to 4. So they're the 2 main areas I think to draw out. There's a number of other items to consider on here, but it's just some of it is
Could we
unchanged.
possibly for somebody to unmute the mobile mic? It's actually the mic that's been broadcasting isn't playing, it's muted.
Thank you.
Thank you.
We can hear you.
Oh,
I think
good.
we just heard you.
Oh, brilliant.
Thanks, Sasha. Yeah, thank you.
Yeah, yeah.
Hi there, sorry, I wasn't sure whether to say anything, but yes, we can now hear you, and I've invited Andrew into this link as well.
Brilliant. Thank you.
Thanks, Sasha.
Thank you, Sasha. So you're asking us just to consider those
2 main ones.
the 2 main ones there. Are there any other comments around the board assurance framework that anybody wants to raise, clarify? I mean, we'll continue to kind of monitor the board assurance framework, and I think the quality kind of presentation next month may give us some need to kind of review where that sits on the back as well. Okay, brilliant. So we're going to move on to governance item reserved to the board, Jane. So this is you. So you've got quite a few things here.
Yeah.
Do you want to take us through?
I do, and I shall. Nigel, I'll come to you when it comes to your part. So item 8 is split into 3 parts, just to make life complicated, I think, for everybody. So I'll work my way through them. So in summary, what you're asked to do is approve the proposed amendment to the audit committee terms of reference. I'll explain what that is. Approve the Digital Data and Innovation Group terms of reference, and to note that the Executive Committee will remain a formal committee of the board. With the terms of reference for that, we'll come back to the board at a later date, but there's a shift in it. There was some consideration about it moving to a group. So if I start with the audit terms of reference, these changes were agreed by the audit committee back in September, following recommendations both from audit chair and the ICB chair, mainly just around allowing more flexibility with the quorum of the actual committee. So that's for you to consider. Shall I stop there? It's a minor amendments.
Yeah,
to the
Yeah, it's a
audit.
minor change.
Yeah.
And you were comfortable with that,
Oh,
weren't you, Stuart? Yeah. I think there's something about as we start to approach kind of the new world that actually we operate openly in transparency. The independent voice around committees is incredibly important, but actually we cannot restrict the business of the organisation by having quoracy that is unachievable. So I kind of think it's a sensible, pragmatic way of amending those terms of reference. And I think if Stuart's comfortable with that, as Chair of Audit, then I would ask the board to support that.
Can I just ask that when these are sent to us for amendments, that it's clear where the amendment has been made?
Yeah, that's a really good point.
Yeah,
Because
we should get track changes. Yeah,
we should, shouldn't we?
yeah.
Yeah.
So we'll take that on board.
Or
and sort of-
highlighted if it's just a
Yeah.
Just the highlights,
Yeah.
just so
Yeah.
that that's
That's
the bit
fine.
that's
Yeah.
different.
We can do that.
Yeah.
definitely.
The one
Otherwise I
board
might
paper.
start tearing apart the rest of it.
Yeah, no, I agree.
Yes.
And gosh.
Yes.
That would
And
be
it's a
scripted
relatively
away.
minor amendment, isn't it? It's yeah. So the one point where track changes is acceptable in the board paper probably is with this.
Yeah.
Yeah.
Thank you.
Yeah, we can definitely do that. And the same for so you'll raise the same point, I'm sure, with the digital data and innovation. That, again, is minor changes updated to reflect its change of status to a group of the board, and the emphasis from it being a decision-making committee to an advisory role. So they're the two minor changes. And I've already mentioned the executive committee to remain as a committee.
Yeah.
In terms of reference to come back for that.
So just for completeness, in terms of the digital data and innovation group, are people happy with those amended terms of reference? I think what we've been saying around terms of reference as we start to approach thoughts about governance of the new organisation is that as much as possible that we can take with us into the new organisation rather than reinventing wheels is quite important. So I think in these revisions we've asked people to have an eye in the prize around future state rather than just where we are today. So, and the executive committee one, it's just been noted, the terms of reference will be with us, I think, at the next meeting. But I think it's important just to clarify, particularly delegated responsibility, the role of the executive committee. So. Okay, so people happy with those items there, Jane? So that's your first lot.
Yeah, now we'll move on to 8B. So these are the policies reserved to the board. There's two that I'm just going to speak to, which are here for noting, and then there's one that Nigel will speak to that's here for approval. So the first one is the local anti-fraud, bribery and corruption policy. This policy has been updated to now include reference to the Economic Crime and Corporate Transparency Act 2023. Specifically section 199, in case you were wondering where it was, and it's probably not highlighted for sure, so we would make sure we do that in future. These amendments ensure the policy remains current, aligned with relevant legislation and best practice. They are minor and therefore in line with the scheme of reservation and delegation that have been approved by the audit committee, so they're now here for noting by the board.
Okay. So in terms of that one, are people happy with the? I mean, we talked about the anti-fraud and bribery requirements, and this amendment has to kind of be made. Are people happy with that?
Yeah,
Even though we haven't highlighted it, Bushra. Yeah. Okay. Super.
The next one is the acceptance and management of petitions policy. This again is here to note. It's been updated as part of the routine process where we review after 2 years. It includes minor amendments, updating of roles, email addresses, information governance and other housekeeping. The amendments were minor and therefore again in line with the scheme of reservation and delegation, could be approved by the Executive Director of Corporate Affairs. In Karina's absence though, the updated policy was reviewed and approved by the Executive Committee.
Okay. So it's a housekeeping update to that policy. Are people happy with that? Okay. And then a new one, Nigel.
Yeah. Can I go on to that? Is that okay? Yeah. So thank you, everybody. This is a policy that establishes a clear framework for commercial sponsorship and joint working between the NHS, our NHS, Humber and North Yorkshire ICB, and the pharmaceutical, medical appliance and the health technology industries. And it's been something that we've been, people have been asking us to do because, of course, as a large large ICB, we do get approaches for this. So this supports a sort of collaborative initiatives that will enhance patient care, deliver local healthcare benefits and maintain overall ethical standards around this. So this policy ensures compliance with national guidance and all industry codes of practice, while safeguarding transparency and integrity in all the engagements that we want to set out. It also sets out responsibilities for our staff to declare sponsorships, manage the conflicts of interest and uphold the professional codes of conduct. Of course, clinical and financial decisions must remain independent of any influence, and especially industry influence. So by implementing this policy, what we want to do is aim to foster an effective partnership that contributes to national and local priorities, of course improving resource efficiency and protecting the interests of the patients and the public. So that's really a sort of a bit of a summary of what we've brought forward, and this has been to the audit committee and has been through that for a check, challenge and approval, and it's coming here for a final approval.
Okay, and I kind of think linking back to conflicts of interest and transparency, I think this is a really significant policy to have. Mark?
So just one question, and apologies if I picked it up in the body of the policy, but in terms of seeking assurance that the policy is being complied with, will that fall to audit committee or will that be somewhere else? Because I'm just conscious that this has some significance in that context.
Yeah. Well, it will lie with myself at the minute as the exec director, but probably to work with yourself and the quality committee in order to about how we should monitor that.
I think audit probably has the role in terms of the check and challenge as to how, and I think there's something about the practical application of it probably sits with quality and clinical, but the actually, you know, the assurance around it, I would hope to come from audit.
I think there's also potentially into the future a role for internal audit as well.
Yeah. Okay, with that clarification, and we kind of need to work through the who does what in terms of the governance around it, but actually in terms of the policy itself, are people happy, the board happy to approve that policy? Superb. And then almost at the end, Jane, C.
Yes, so what you have in front of you is our annual fit and proper person declaration that we need to make. You will see, the paper's really self-explanatory, but you will see that we've gone through a number of items for that fit and proper person check as required. So the self-attestation forms that were completed by all board members, appraisals, the annual background checks. The review of evidence was delegated to the governance and compliance team, and the head of governance and compliance prepared the return, which was reviewed by myself. The HR team record the fit and proper person outcomes, and the documentation is securely stored in line with data protection requirements. We then submit that across to NHS England, so a total of 20 individuals underwent that assessment that was signed off by ourselves and then countersigned by the NHSE Regional Director, confirming the position for 24-25. So for the board to receive assurance that we've complied with our regulations and submitted the annual return, and note that the fit and proper person test processes are an ongoing process and part of our regulatory compliance.
Okay, so we need to bring this to the board, just as the board is assured that we have undertaken our obligations. And just a huge, massive thank you. I mean, this looks really simple on one page, but actually the huge amount of work, as you know from the volume of emails that ask you to fill in forms and sign things and approve things, and, but actually, you know, the purpose of this is to assure ourselves in terms of the fit and proper nature of members of this board, and also that public accountability. So I'm pleased to be able to bring that to you today. Michelle?
Yeah, thanks. Good report, standard report, but good to see, and it's a lot of work going on in the background, so I can appreciate that. I just wondered, on it, obviously it says some of the areas that we looked at, does the ICB check social media?
Yeah.
I just think if we just need to make a record of that, I think the public might be quite interested to know that we did that. Yeah. We did a bit of a scrutiny on that, because I know that we do.
Yeah.
I think it's a really important point. I kind of think there is more to this than just things on this list. So I think if we could, you know, and certainly can put that in terms of future. Just on the back of that as well, the other thing that we are attempting to navigate at the moment is mandatory training and around the requirements to kind of do mandatory training as part of fit and proper. And I think we're trying to, certainly my intention with that is to make that as simple as possible and not to confuse people. And to be really clear, I think, we need to think about the fact that, people are within organisations, partner organisations, already doing this stuff within their organisations. So we have to be much more receptive to the fact that people already have training and not insist that the ICB needs to do the training again. So I'm planning on, at some point in the future, making sure that you've all got little training cards that tell you what you need to do, which is far easier than kind of getting endless emails telling you how to do things. I'm particularly looking forward to resuscitation, to be honest. I'm looking forward to that one, although I'll be using it mildly. Anything else on there? Okay, so happy to approve that one. So we're moving into the strategy part of the agenda. So the chair's report, I'm not going to dwell on this. You've had time to read my kind of musings, just to kind of touch on some stuff. So I talk about Amanda joining us, which is really well anticipated. We'll have further conversation around the mid-year review as part of the meeting later. But I just wanted to reflect that being able to sit down, I think with people and think about the work we've done over the past 6 months as an organisation system, I think was really valuable to take some time out to do that, and to actually be able to reflect on some of the priorities and challenges we have for the next 6 months towards the end of the year. So we'll pick up on the outcomes of the mid-year review process later on in the meeting. I'm not going to dwell on organisational change and transition. This is a report that was a point in time. We've got more information about that for you we'll touch on it in part 1, but much more information in part 2 around transition. But just to say, this is all that balancing act at the minute between future ICB and current ICB, and being able to do both at once. I think the fact that people have done that and actually done the stuff that they are doing, they're doing stuff they're doing at the moment, is a real credit to both the ICB and our partners as well. It's not easy to kind of be focusing on today while you're anxious about tomorrow, but I think we have navigated that really well, and I'm very appreciative of that. We've got a presentation a bit later, haven't we, Anya, around the future kind of proposals around our integrated care partnership, and we did host the last meeting on 22nd of October, which kind of felt a very energetic kind of opportunity to talk to a wide range of partners, particularly local government, around key issues and priorities and a new way of working. And whilst the new proposals for ICBs kind of look to destatute integrated care partnerships, I think we remain committed to the strength of our partnerships and our collaborations, and how actually those partnership forums are going to be really important to us in terms of how we develop as a strong strategic commissioner. So Anya's got, not to steal Anya's thunder, but some slides to talk about the new proposals around the integrated care partnership. And then later on in the agenda today, we're going to have the presentations around the Get Britain Working Programme, which has been a key element of our engagement with our mayoral combined authorities, that new relationship signalled by the 10-year plan. And actually, Jane and I, we had an opportunity last week, particularly in Olney's riding, to kind of be part of a skills roundtable that kind of looked at the relationship between the NHS and the combined authority around that skills agenda. I know that Caroline's in the room, Michelle, your chair, a really important kind of conversation to start to navigate and embrace the grey area between mayoral responsibilities and the NHS, and very much the NHS as a key strategic partner. So we really valued that, and the Get Britain Working stuff that we will see later on, which I think Jane talked about last time as the intro, is a real opportunity to think about what that relationship kind of looks like in practice. So that's presentable information to the board today, but a lot of attention kind of is being spent to those relationships we need to develop for the new world. And also, just as just to let you know, we are hosting a visit in 2 weeks' time from the Department of Health and Social Care, particularly focused on our workforce transformation piece, particularly interested in breakthrough, particularly interested in the stuff you're going to see this morning around the people dashboard, but a real opportunity, I think, to showcase the work we have done around workforce transformation and how that starts to then influence some of the thinking around the development of national workforce strategies, and particularly that crossover between health and social care because actually our approach has always been one workforce rather than different workforces, and so we have an opportunity to kind of influence through that as well. So huge appreciation to everybody who's been involved in the planning, and apologies for me just going, yeah, why don't you come, why don't you come? So, okay, any questions there? Okay, so Teresa, your thoughts?
Yeah, thank you. My report this month is quite light for two reasons really. Firstly, of course, I've been on holiday for part of the month. But more importantly, because actually the key elements of significance really of things that we will be talking about in other parts of the meeting, both the mid-year review and the ICB reorganisation. So you've got the report. I'm just going to comment on a couple of things. So firstly on the national update, and what I'm trying to do with these national updates beyond the transition, etc., is just to actually highlight and inform around either significant clinical developments or significant changes really that will impact on the context within which the ICB is working. So the one that I would just mention particularly is the medical training review, and I'll ask Nigel to add if there's any comments he wants to make in a minute, but the Chief Medical Officer has looked back over the medical training over the last 15 years, and really it's a question about is it now fit for purpose given everything else that has changed, the world's changed around it, both disease epidemiology and really the ambitions and aspirations of individuals who enter medical training as well as technological changes. So that will be significant into the future and will change some of the context we're working. Nigel, is there anything you want to?
I think probably for us as an ICB it's about, and others in the room might have an opinion, is when we think about postgraduate medical training we think about specialisms a lot, but actually our shift and our 3 shifts is not about specialisms, it's about skilled generalism. And I do think this misses a trick about actually where we need to start to position our training, because historically training, as people know, you do 5 years at medical school, sort of registration year, and then you're into your specialist training. And most of that specialist training, even if you are based in the community, like ourselves as GPs, some of us in the room, it rotates around the hospital. So straight away we're hospital centric. And actually the 3 shifts tell us not to be hospital centric. So I think it outlines what people miss and what people want, and that the report brings in from 8,000 resident doctors to do this. And some of the things absolutely I would completely agree with, sort of team structures really do matter, and we know that, don't we? You know, if you're part of a team, how you feel, how you build, those relationships, understand how to learn. And of course there is a growing proportion of doctors that do work in different ways as well, and outside of those more traditional posts. So I think it's a good step forward, but actually I just wonder whether for that next step into what actually medical staffing and needs to be, it doesn't really outline that, so it needs to come together for me.
So more work?
I think so.
More focus, isn't it? I think.
Yeah, and I suppose for us, when we're thinking about commissioning in the future, and we're starting to move, or we think we should be moving certain things, what's the workforce that needs to start to catch that, and how do we start to get into that training and doing that? So I think that's the real trick for me.
Mark.
Yeah, so just, I mean, now just covered some of the things I was interested in a lot more, with a lot more knowledge than I've got. But I think the thing that just strikes me is this sounds like a really interesting, really sensible path to walk down. I guess I was just left thinking, well, what do we need to do? And is there a call to action? And we should, because it's there as recommendations. Do we need to be doing something as a result of this at this point? And if so, what is it?
Yeah, I mean, the only thing I would say is that the other big link, which partly answers your question, Mark, is that we also need to be conscious of the shift of workload into non-hospital settings, including in the training of the medical professions, but also wider medicine and allied health professionals in the future, has an estates implication. And one of the things we need to be thinking now is where we're working with providers around the commissioning of estate, that we need to think about the future training needs, not the current training needs, because this is signalling a significant change. Probably, I agree, Nigel, not as much and as strongly as it needs to. It's still very hospital centric, but we need to be building that in. We know the single biggest reason currently for general practice is to be limiting the number of trainings they can take, which is having a significant impact on the workforce planning of NHS England, is estate considerations. They simply don't have the rooms to put more training doctors in.
Okay, so we're going to go Teresa, Jane,
I'll just
Stuart.
thank you. I just don't think we should miss Mark's question about is there something for us to do. My response at this moment in time, and I'm going to turn to Jane in a second, my response is we don't know all that we need to do yet. And the reason I say that is because there's development of a national workforce plan, there's changes to how education and training across England will be developed and delivered. So we need to be part of that work that's happening nationally, and then we'll truly understand exactly what we need to be doing.
So Jane, there's a segue for you there.
Well, it was exactly my point, actually.
Oh, right.
There's going to be a national workforce plan, and that's been delayed slightly to get more feedback, and now is timed as spring 26, I think, at the end of the year. But the other thing, I think, is the review at regions with the model region around how they're going to manage workforce training and education, and that will also, I think, have some impact in the actions that we end up taking with where the responsibility and accountabilities lie.
And I think, just for bringing Stuart in, I think also the thing around the workforce planning bit, and I think when you see the People's Joy dashboard, I think we are quite smart in kind of recognising that our future workforce needs are probably not what we assume them to be, and it will be different. So we need to start planning for that now. We can't just suddenly change track. So how we use the data we have around current workforce and future workforce is going to be incredibly important. And I think we've got a really strong, when you see the dashboard, a really strong basis in which to start having the conversations which will challenge some of our thinking and confirm other bits of our thinking as well. And then the other bit around, and I think it's Simon's point around, as part of commissioning there is a workforce question that says, what does the workforce look like to deliver really effective neighbourhood health? Because actually it is going to be a whole different set of kind of people. So how do we start to use commissioning as a tool to have a workforce conversation rather than workforce just being a conversation we have somewhere else? Because actually this very much, and I thoroughly agree, I've said on a number of occasions that the role of allied health professionals in particular in neighbourhood health is incredibly important, and actually that's a workforce that is already strong, but actually the opportunity to grow and develop our current workforce using, and actually a lot of the new world is about how we recognise the assets we have and unlock the potential of those assets, and I think workforce and how we respond to our future role as Commissioner is going to be incredibly important. Stuart.
Thank you. So I think as a Commissioner, we would expect that anybody providing us with the services that need this kind of training would be able to assure us that their folks were getting appropriate training, probably through what I think we call a career planning session, but essentially what are you going to do over the next year development session with anybody who's a medically qualified member of staff, which ought to contain quality enhancing stuff, which is basically training to keep you up to date or move you on to whatever the next stage is of your career. Somewhere in our papers we have a report that says only about half, I can't remember the stats, Jane, I think they're probably in the papers, have such a performance plan.
Yeah.
So as a Commissioner, we find that unacceptable if that, I don't know if the stat just applies to ICB staff or to everybody in our system, but whoever we are commissioning work from has to come up to standard on this, otherwise we have to be worried about the quality of their work.
Yeah, so I think there's,
Are you going to say it?
I'm coming at it from I know you will have a different perspective, I'm going to come at this from a commissioning perspective, and that would be part of the contractual requirements, and probably is part of the contractual requirements in the general
And so
contract.
we could see data that says
Yes.
that our
Yeah, yeah.
providers will do.
And we see that routinely as part of some of the quality meetings that we have, because there's mandatory training, compliance, etc. Yeah.
Bushra.
But I think Mark is referring to doesn't apply to medical staff, because medical staff who are consultant level or equivalent, who's CCT, all have an appraisal. It's in our separate appraisal that we would meet those requirements and be performing quality improvement, we would be doing audit of the week, we would be
So that
demonstrating
provides the function I'm asking for already.
yes, but that is happening elsewhere, and I think it would be unreasonable to expect doctors to do it twice.
No, so if there's a process,
It's
that's
the
great.
assurance,
It's just
isn't
a matter of
it?
extracting from that
Yeah, it's
assurance
the-
that people are up to date
the-
on.
So that's
Sure.
all covered in appraisal and revalidation, which happens every 5 years, appraisal is every year, and employers just make sure that we still have that, don't we?
Yes, and I guess just to round that off, and we know from the work we've done around the workforce piece, don't we, Jane, that actually training and support and continuous development are key elements of recruitment and retention. And actually they're the things that actually are really pressurised in a really busy kind of system. The thing that we don't want to slip is that ongoing support, because we do know there is an exit route when people do not feel they are supported and developed in the roles they have within our system. Louise, I'll give you the final word.
Yeah, just offer assurance that the same is true for public health professionals who are public health consultants, that go to exactly the same as what you've just described, Bushra, because we do have people, backgrounds other than medicine, that are in professionally registered roles, as well as medics in public health as well.
Yeah.
So this board could receive a report that says all our providers are compliant, or not, as the case may be. The data already exists by the sound of it.
I mean, let's pick that up in a conversation, I suppose, Jane, in terms of actually how easy that is and whether or not that does sit, because that information is there. And I think just being really clear, it's for assurance purposes, just to understand. I suppose. So let's pick up a conversation separately around, is that possible? If so, what might it look like?
Well, each organisation does its own assurance on that. So it's for what purpose would we want that assurance in isolation from a broader piece?
And I guess the piece you talk about is just that we just understand there is assurance in place.
Yeah, we should know that we're getting quality products if we're spending all this money with these providers.
Let's work it through to see what that might look like. So I don't want to create huge amounts of work.
No, I don't think it's a separate report. I think in the new world, it will be part of our contract quality monitoring reports.
Great. Yeah. Okay. So we don't need to do that then, Jane? Yeah. I'm conscious that you've obviously got nothing to do at the minute, Jane, so there's time on your hands to do things. Okay, look what you've started with what you said was going to be a short item, Therese. So I'm just going to put that out.
There's only one other thing I want to highlight, and that's the regional update around the LMNS, which this board will recall, because we usually have the reports of the peer review visits that happen on an annual basis, which are part of our quality assessment and assurance process, and the national returns we do around the maternity investment standards. So this is an example of the changing landscape in action. So as part of the future role of the ICB, we will not be undertaking those visits from an assurance perspective. We'll be doing something different through a quality contract monitoring perspective. So as part of the transfer to the new model region, that responsibility is transferring in year, so the next visits will be under the auspices of regionally led as opposed to ICB led. We will still be obviously participating with those, and as I say, we will be building our own contract quality monitoring arrangements in respect of maternity services that will draw on some of this peer review information.
Okay. Any questions for Therese on that one? Sure.
That sounds as if there's two processes trying to do the same thing to me. I don't quite understand. If the regional team do a good job, can we not just receive their reports and use that?
Yes.
We don't need anything more elaborate than that, assuming they do a
That's what I'm trying to say. We will be reporting from a contract quality perspective. If they're doing the visits and we're getting the assurance and we're participating in that, we'll be feeding that data through to our quality contract monitoring.
So we don't need to do it twice.
Yeah.
All joins up. Okay, any other questions for Teresa? I think to make another reference, we're emphasising that point about the executive committee, aren't we?
Well, yes, it's just in case he doesn't miss it.
Yeah. Has everybody reflected on the future of the executive committee and like to ask some questions now they have another opportunity? I think you might be somewhere else in the papers as well. So.
Well, that's all right.
Yeah? Okay, superb. So we're going to move on to the transition committee feedback. So again, I'm conscious we're in public and we've got a chance to have much more detail about this in part 2.
Yes.
And I guess that this is for the first time we can say, is there any news?
Yes, there is movement, as most people were probably aware, at least from seeing the media, if nothing else, yesterday. So for many, many weeks we have, there's been noises about movement, hasn't there, with the Treasury, but nothing really coming to fruition. And certainly, and I would want to say this publicly, the amount of time that this has gone on for and the impact that that has had on our people can't be underestimated, and I think every single ICB is probably saying the same. However, having said that, you will have noticed that yesterday, well, starting at the end of last week, there was definitely some movement, and that was made more public yesterday. We received some guidance late yesterday afternoon. As an ICB, we briefed our senior leadership team yesterday morning, and then our whole workforce in advance of any of that guidance coming, because we wanted them to hear it before anything was in the media actually, and I think in hindsight we made exactly the right decision because it was in the media by the afternoon. So we have made some commitment to some quite tight time frames, and we're just working through the guidance that came through yesterday. We'll continue to work through that and also get some clarity around what all of that means for the money. Both of those things need to be in place before we can progress, but at the Transition Committee yesterday, in terms of our fortnightly stop-go, we had an extraordinary committee and made the decision that we would be progressing subject to implementing the guidance and the money. As you say, Chair, we'll talk about that in further detail later.
Yeah. So we're at the point now where I'm very confident that as an ICB we have a plan, and actually everything is in place for that plan for us to gather the assurances that we need. And we will need to talk to the board in an extraordinary meeting probably next week, just around progressing. So it's just to alert you that we will do that virtually. It's important the board decide us on this at a point where we have the information that we need to share with the board, but it's just to alert people that we may be asking you for some of your time for a virtual meeting next week, just for the board to look at a single agenda item around transition. Okay, I mean, any other kind of detailed questions we can pick up in part 2. So the Secretary of State is speaking at NHS providers today and is going to announce all of this, even though it's been leaked and trailed already. But he is going to announce that this is the start of the changes to the NHS that he promised what felt like a very long time ago. In fact, it was a very long time ago. You know, just the reassurance that actually we are doing everything we can organisationally to support our staff through a period of change, and that actually our commitment is to continue to deliver high quality services to our local populations through this period of change as well. Okay, so any questions, we can pick those up in part 2. Okay, and this is why, you know, writing a report, you know, a couple of days in advance is just, you know, actually the world changes. You know, the world changes literally, kind of on a Friday afternoon, the world changes. Okay, so we're going to move on. So I've already touched on Anya. I don't know how we're doing for presentations. Can you share on the screen?
I believe so.
Can we share the ICP presentation? So I've already touched on this, that we held a meeting on the 22nd of October of our reconfigured integrated care partnership, and I think what Anya will share with you now, or people can see it, so I'm sure that's not what Fun was doing, is talk to you around our proposals around the ICP kind of moving forward, where we've kind of got to in terms of some of the stuff around governance and roles and responsibilities, and then to get the board's feedback on that connection between the work of the ICP, very much our creative ideas generating kind of group of people, and how that fits into our role in the future as a strategic commissioner and a strong system partner. So, Anya.
Thank you, Chair, and apologies, colleagues. Some of you will have to spin your chairs round to see the only screen that is working for us today. I will just canter through these slides which set out, as the Chair has just said, the proposal for the way forward for the Integrated Care Partnership. As you can see on the headline slide, we had a system workshop back on the 25th of June, and then a further meeting of the Partnership Redesign Group on the 7th of August, and also presented this on the 22nd of October, just a couple of weeks ago, to the Integrated Partnership, and there was much endorsement and positivity around this approach. And firstly, I think it's fair to say, and the Chair touched on this, of course, moving forward in the new world and new NHS model, there will no longer be the statutory requirement to have an ICP, but that was one of the first things we discussed with our partnership, and I think it's really crucial to really flag the word partnership, because absolutely all partners said we cannot lose this way of working that we've got, and that the relationships, the partnership that we do have. So although it's not a statutory requirement, there was absolute 100% buy-in and support for continuing partnership arrangements, but in a different way that I'll unpack a little bit further. So of course within the frame, if you like, there are three distinct yet connected spaces and interactions, and I'm just going to unpack a little bit the partnership, but also of course the governance and the democratic scrutiny which continues. So if we can move forward please. This was just the headlines from that initial workshop of what needs to, or what partners felt needed to be different. So again, a lot of support for more shared ownership, more inclusivity, creating together rather than it feeling sometimes that it's either the NHS or another partner almost directing, instructing rather than co-creating. So a lot of that came forward. Absolutely to have focus and follow through, so really focusing on partnership actions and how we can demonstrate the impact, cohesion, flexibility, openness, and as I've just touched on, outcomes focus. The things that we absolutely wanted to move away from was this sense of control, exclusivity, fragmentation, formality, and process focus, so that it's a much more agile function and partnership really that we're looking for. So if we can move on please. So these were the draft principles that were set out, and again much agreement with this at the very recent ICP. I won't read them out verbatim because you can see there on the screen, but again really echoing everything that I've just said in terms of the sentiment around shared ownership, clear roles and responsibilities, working as a system, very open and transparent and supportive communication, strengths-based, and fundamentally making a difference. I think everybody acknowledges that to address some of the challenges and opportunities that we have within our communities, within our population, no one partner can do that in isolation. So we have to keep looking through that partnership lens and looking at the outcomes that we want to achieve working with our communities and population, not doing two. So in terms of, if we can move on please, sorry, in terms of how this then looks, in terms of a renewed partnership model, hopefully you can see this slide. But this is just setting out sort of the programme, the schedule if you like. So we will have bi-monthly partnership development events, which is really bringing together a much broader group of partners and colleagues, being super inclusive if you like, around engaging those partners and colleagues at a formative stage in those key matters of health and care for our population aligned to our strategy. and then feeding that into the steering and oversight board in terms of how that then translates into plans and actions, and again shared plans and actions, not any one partner holding the responsibility for that. And then we'd notionally said May to have an annual assembly that is more of a sort of thought leadership, for want of a better word, space in terms of inspiring our leaders, looking into and over the horizon and thinking about how we're putting Humber and North Yorkshire on national footing from a strategy and policy perspective in terms of some of the excellent work that is happening here and all the things that are in train and all that we want to deliver in the future. And as I've just touched on, finally, on a quarterly basis, the steering and oversight board to meet to develop the plans and actions, and again that strong focus on mutual accountability, everything linking back to the ICB strategy that we've said at board multiple times. There is still huge support for the strategy and ambition within the strategy, and how we take that forward in terms of shared action. So that just gives you an overview of how the partnership will work in the future. And then if we can just move on, just to unpack a little bit more, because some of you will be more familiar with some of these component parts in terms of the structures. So these are the structures that are being or have been stood down. So as we've just touched on, the statutory, if you like, integrated, the formal integrated care partnership will be stood down and replaced by what I've just said. And the Futures Group, which some colleagues will have been familiar with, which did some great work in terms of what I've just described, in terms of that looking almost into the horizon and shaping some of those key big ticket items. That has been stood down but will be overtaken, as I've just described, by the partnership development events, which will draw on the same energy and spirit of innovation. Then if we can move forward, please, Emma, the structures that have evolved, the System Leaders Forum, which again, I think all partners are involved in some way. So we now have a bi-monthly senior NHS only senior leaders forum, and then on alternate months again we've got the broader System Leaders Forum, and again there's much more agility in that depending on the agenda. So as an example, the last one last week was around neighbourhood health, which brought in a much broader set of partners for that agenda. So I think there's something in agility in all of this to respond to the themes and the key topics and strategic items. If I can just move forward, so very quickly, you can just sort of see here the way that we want this to work, and again really focusing on that approach of inclusivity and again agility, which is a word I keep using, but bringing in relevant partners as and when, and not feeling exclusive in any way. And we've actually, I think the chair's been quite clear that we don't ever expect it to be a set audience, if you like, because some of it will be self-selecting from partners as to what's more relevant for them. Some will be, will be inviting more people to come into the conversation. And then just finally, and I think quite topical given another item on our agenda today, clearly, and we've touched on this a number of times, the NHS 10-year plan absolutely signals that evolving and growing role for our combined mayoral authorities. So again, we have invited our three mayoral authorities into the partnership, and we look forward to developing that relationship as part of the renewed partnership much further over coming months. So I hope that was just a helpful run through of the evolution. Thank you. I'm not sure if you want to add anything, Chair.
And I guess for me there's something about, so you may have seen last week they published the Strategic Commissioning Framework, and there was a strong emphasis in there on partnership. Actually, in lots of ways it's about the partnership with local government, it's about how the NHS joins up with everybody else, and I think we've always been committed, certainly in Humber and North Yorkshire, that actually the partnership element of our work, our collaboration with communities, with providers, with other kind of stakeholders was key to our success. We can't deliver anything around the challenge in the 10-year plan without having those very strong relationships, and our commitment in the new world to continue to develop them. What's really interesting is the partnership forum, actually that ability to have a conversation with a wider group of stakeholders about how we can make stuff happen, even if that stuff isn't our responsibility. And I think we had a good conversation last time, which was around neighbourhood health and community transport. Community transport is a big thing at the moment. Everybody wants to talk to me about transport. But actually the ability, particularly in North Yorkshire, parts of East Riding, to get from A to B in terms of to attend appointments that might be health appointments that actually might be going to a lunch club in the next village is incredibly important. And there was a really good conversation that said the NHS has a bit to do with transport, local government has a lot to do with transport, and the transport responsibility in the new world sits with mayors. So actually, how does the ICP become the ability to have a conversation that has the proper conversation about transport and actually kind of recognises that everybody's got a role to play in it rather than just in one person's responsibility. So, excuse me, really, really positive in terms of doing that, and also very much in terms of that connectivity between our wider partnership arrangement and other partnerships. So I think at our last meeting, our last private meeting, we talked about anchor networks around things that are being developed. Was the ICB involved, not involved? There is something around creating a space where people can come together. That doesn't mean you've got to go to 15 different anchor networks. So how does it become useful to everybody? And actually, how do we develop something that's much more thematic in the approach? And very much that bit that says, if we are going to today talk about transport, if you're interested in transport, come to the conversation. If you're not, you're really interested in I don't know, fungal toenail infection, come to the next one, because that's when we're going to have that conversation. Gets us a real mix of people, and actually very much an open invitation to our vulnerable sector partners, communities, local government, people who are kind of interested. And very much we had a really interesting, and this is the style I think we're really keen, aren't we, Annie, to kind of develop with this partnership, is we held the last meeting and we had a big conversation around formal minutes, didn't we? Is it going to be formal minutes? Is it going to be, who was there, who wasn't there, who apologised? I think the approach we've taken, and I think we can probably share it with the boards as well, is rather than formal minutes, we've done something that's very interactive in terms of saying to people, these are the things we talked about, these are the things that are really important. It looks not like a formal set of minutes, it looks like something that you might want to come to the next meeting around, I think. So very much the style of this, partnership is important, but the way the ICB is a partner in this rather than leading this, and actually still being able, safe around governance, but being able to say, this is the place where the innovation happens, the creativity happens. It isn't always about the NHS having money for things, because that group of people could say, we're going to make this happen and this is how we're going to do it. So quite exciting to kind of do something alongside our main body of work, and a really useful reference point at the last meeting, I thought, for a different perspective on neighbourhood health. Which was really good. And actually, despite the fact we had dwindling attendance about a year ago around the ICP, now loads and loads of people are coming to it. We've got a big invitation list. They all can't come at once because we don't have a room that seats 500. I'm just saying that. Any questions around the ICP? Some of you were with us at the ICP. Michelle?
Yes, thanks, well presented and great. And I think everybody understands the importance of the ICP, but I'm going to put it in a bit of realistic context, I think, if that's okay. Just bear with me. Because obviously we just spoke a bit about the cost of the ICB going forward, so I was just wondering, one, for that, I'm not asking the answer now, but I think we've got to be mindful of that and cognizant. I'm sure you have, but these things take a lot of time and effort to run and admin. So I think the issue for me would be the so what question. I think you've articulated a little bit about what you've just said, Jessica, but so what is this adding benefit to what we do? How's that linking into our strategic commissioning role? How's that linking into our population health piece? And how's that linking into neighbourhoods? I think the senior leadership board, for me, and I've been speaking to a couple of CEOs, obviously I'm a partner rep on here, I think we do need to have a bit of a stock take about that. I think Teresa started to do a bit of that already with the bi-monthly piece, but I think it needs to be a lot more focused in what it's trying to do, and I know that others will have that conversation. So I think for me, and also the link into place from the ICP, where's that linking into the place? You mentioned a bit about the mayoral pieces of work, which are gathering a bit of momentum, which is great. But I also don't want to raise expectations either, because sometimes when we get into a room and talk about housing, people go away thinking everything's going to be done by the ICB, everything's going to be done by the NHS, and in fact we can't do that. So I think it's about, so for me, expenditure, cost, making sure it's focused, so what questions, what outcomes are we trying to achieve, how does that link into the strategic view of commissioning population health and neighbourhoods, right? And can we get that place mayoral piece a little bit more grounded in there, and how do we really maintain people's expectations, as opposed to some of what I've just said. So it's more a general comment based on a load of questions. It's, it is important, but I think we've got to get that balance right.
And that's really, really helpful. Teresa?
Yeah, thanks, Michelle. I agree with a lot what Michelle's just said. I think the point I want to make, though, is obviously the ICP is pretty fundamental, I think, in terms of the ICBs can only be effective into the future if we have got a focus on partnership working. And the ICP, as I say, is fundamental to that. However, what I would say is the ICP is not the only mechanism by which we will be focusing and working around a partnership. And one of the really important elements is the joint committees with the local authorities at each of our 6 places. So that those joint committees will be equally important going forward in terms of how we deliver on our partnership responsibilities.
And part of this, I think, is about as we move forward with transition and start to have a conversation about the governance that sits around that and all the bits that we need to kind of enable us to do that security job. We need to kind of take stock of everything we do, and actually there's some stuff we need to enhance. I suppose I'm really committed, knowing how busy every Revenue Taker is that we need to maximise the spaces where we kind of come together and not create even more. So actually we need to be much more efficient in how we kind of work. And I think one of the things that struck me, Anya, I think from the conversation we had with the ICP at the start, was that real sense of frustration. It goes back to your outcomes piece and the so what question, kind of, Michelle. The ICP was saying, we've had some great conversations here. We've got great things that we feel that we've done, but actually it's gone nowhere. So actually, what's that commitment to kind of follow through and to kind of, have an honest conversation around, is this achievable? And actually, some of this is about the confidence that actually everyone around that table will commit to their bit of the puzzle. Because community transport is a really good example where actually it's everybody's business and nobody's business, but actually it's about the conversations that join up what happens within mayoral combined authorities, local authorities, the NHS, the VCS providers who do community transport. How does this then link across to a neighbourhood health offer, which might be about, in some of our more rural parts of our patch, how do people get from A to B, not because they've got a leg that's dropping off or a serious illness, but because actually the one kind of contact they have in that week is the lunch club in the village next door. And I think that is incredibly, that is important to me as being able to kind of get to some of the clinical services. So I think very much a work in progress, really much, kind of encouraging the board, being part of that, kind of joining us in that, helping us kind of shape those conversations. Stuart?
It's only a quick admin point. We've got 2 presentations on the day. I assume they'll get circulated so that we can follow up.
Yes, and they will, yes, definitely. Okay, any other questions around the ICP? So our next meeting is January, and I think we're going to talk about skills from memory.
Yep.
So if you're interested in a skills conversation, we can give you the date and get that in your diary now. Super. No, so the next thing on the agenda, so Anya, we're going to defer the demonstration, People's Story Dashboard is coming in a minute. Just to let people know that in terms of the Voice of the Experience presentation, we're going to defer that to next month because the technology will not allow us to do that, and I kind of think this is probably too important for us to kind of do in a half-hearted way. So with huge apologies, we won't do that, but we'll pick that up. Is that okay?
Yeah, may I just formally just apologise therefore to the community of the Hull and East Yorkshire Centre for the Deaf and Sarah Reagan, the manager, because they were expecting that this would be presented today, and they've given us the time and insight really richly, and I just want to apologise for the delay and technical issues. Formally, thank you, Chair.
And I'd like to add mine in there as well. So technology has defeated us today, but we will give it the space and time it deserves in December. Okay, so we're going to move forward. So just checking, have Andy and John joined us yet, Emma? No, I think they have at the moment. So it looks as though you've probably got 5 minutes to grab coffee and use the facilities before they get here, of course, to the people who are down for the presentation. Have we checked that they can still do that presentation? Yeah? Yeah, okay. But so 5 minutes and then back in the room.